The healing properties of music have been known since biblical times. Music opens a spiritual window. When I first brought a tape recorder into the OR, it was considered an explosion hazard. But we ran it on batteries, and then the nurses and anesthesiologists felt so much better that if I forgot my music, they'd ask for it. I encourage patients to use tapes of whatever music they find most relaxing or healing in order to adapt the hospital environment to a healing environment. One patient listening to harp music just before the operation began said, "It's a good thing I heard that while I'm awake. If I woke up and heard it, I wouldn't know where I was." Another day, a patient under local anesthesia started laughing and said, "Most appropriate," while I was removing a large benign tumor. In the background, Frank Sinatra was singing, "Why Not Take All of Me?" The mechanic and the healer. The value of identifying with the patient explains why the best doctors are often those who've been seriously ill themselves. Throughout our training, we learn not to empathize with the sick, supposedly to save us psychic strain. All our terminology emphasizes the separation. Instead of a heart attack, the hospital page operator says, "Code 5." The emotional distance hurts both parties, however. We withdraw just when the patient needs us most. Nurses know how hard it is to find the doctor when a patient is dying. All our education encourages us to think of ourselves as gods of repair, miracle workers. When we can't fix what's broken, we crawl off to lick our wounds, feeling like failures. The distance also encourages doctors to feel invulnerable. It's always other people who are sick, not me. When I tell a room full of medical students almost everybody dies, they all laugh. But when I say the same line to a room full of doctors, there's dead silence. We become the best deniers of all. A severe staph infection, which once kept me in a hospital for a week, was a crucial part of my education. I found out the difficulties of being in isolation, hooked up to an intravenous line, required to call for help for everything I needed when I was used to being responsible and in control. I found how hard it is to maintain your dignity in the skimpy gowns that the hospital provides. This illness came at a time of many changes in my life. A new home, more children, starting practice, all positive events, and yet I became ill. It made me aware that patients in my office must be experiencing similar things. I began to joke with them about changes in their lives. I would ask, "Did you get a new job? Did you move to a new house?" They were astonished. How did I know? I learned more about what doctors were like, too, since I was a physician. I had eminent professors caring for me, but I couldn't get them all together at one time to give me a straight answer. They even wanted to move me to a more depressing windowless ward because it was closer to one professor's office. I said no and told them I was leaving the hospital. Suddenly, everyone showed up. I think a few days as a patient on a busy ward should be an integral part of every physician's training, including, as one patient recently added, an IV in his arm and a tube up his nose. Most tribal cultures recognize a similar necessity. Usually one cannot become a healer without first passing through sickness to health. The denial of empathy benefits no one. As mechanics, we doctors always fail in the long run. But as counselors, teachers, healers, and caregivers, we can always contribute and even help at the moment of death. Then there's no need to hide in the cafeteria with the beeper and force the nurse to face the patient's death alone. A cooperative arrangement in which the doctor and patient both realize that they are essentially the same, except for a few years' training, offers more to both than the accustomed roles of master and supplicant. This expanded outlook helps a doctor to inspire hope, give with the heart as well as with the head and hands, keep ego in the background, and share major decisions with the patient. The love returns in words and looks of gratitude, in cards and letters, and in little gifts for the office, all of which restore you. A doctor who acts out of love doesn't burn out. He or she may get tired physically, but not emotionally. The wonders produced by close doctor-patient collaboration never cease to amaze me. Thelma, a patient with recurrent breast cancer, came to me and said that she wanted God to heal her while I observed and monitored the process. I explained how difficult I thought that would be. On her next visit, the cancer was smaller, and I asked her what had happened. She said, "I left the house with the phone ringing." It was the first time she'd ever said no to anything. Next time, her cancer was even smaller. Again, I asked what had happened. All smiles, she said, When my alcoholic husband acted up, I called the police. He said, "You're embarrassing me in front of the neighbors." I told him, "I have cancer now, and I don't accept your behavior anymore." By the third visit, however, she realized how much I cared for her, and we became a team. She said, "It's hard work becoming a saint and healing yourself. Why don't you operate and remove the tumor? I'll work on staying well." Thelma told me that the night after surgery, the nurse came in, pulled the curtain, and said, "Tell me about Dr. Siegel." My patient responded, "What do you mean? You act like you think he hypnotized me." The nurse said, "Well, you've had a radical mastectomy, and yet you're walking around the ward cheering up the rest of us, and you have no pain. What did he do to you?" He shared with me, "This was our decision, so there's no reason for me to be depressed or in pain. I know the right thing was done to me by the right person. This is my way of getting well." We physicians must become instruments. When that happens, motivated patients will use us to work miracles. Disease and the mind. The mind, benign or malign. Part of the mind's effect on health is direct and conscious. The extent to which we love ourselves determines whether we eat right, get enough sleep, smoke, wear seatbelts, exercise, and so on. Each of these choices is a statement of how much we care about living. These decisions control about 90% of the factors that determine our state of health. The trouble is that most people's motivation to attend to these basics is deflected by attitudes hidden from everyday awareness. As a result, many of us have mixed intentions. Consider, for example, Sarah, a woman who came to me with breast cancer a few years ago. She was smoking when I walked into her hospital room. Her action clearly stated, "I want you to get rid of my cancer, but I'm ambivalent about living, so I think I'll risk a second cancer." She looked up sheepishly and said, "I suppose you're going to tell me to stop smoking." "No," I said. "I'm going to tell you to love yourself. Then you'll stop." She thought for a moment and replied, "Well, I do love myself. I just don't adore myself." Sarah ultimately did come to adore herself and stopped smoking. It was a good quip, but it exemplified an important problem many people have with themselves. Self-love has come to mean only vanity and narcissism. The pride of being and the determination to care for our own needs have gone out of the meaning. Nevertheless, an unreserved, positive self-adoration remains the essence of health, the most important asset a patient must gain to become exceptional. Self-esteem and self-love are not sinful. They make living a joy instead of a chore. The mind does not act only through our conscious choices, however. Many of its effects are achieved directly on the body's tissues without any awareness on our part. Consider some of our common expressions. "He's a pain in the neck." "He's a pain in the ass." "Get off my back." "The problem is eating me up alive." "You're breaking my heart." The body responds to the mind's messages, whether conscious or unconscious. We don't yet understand all the ways in which brain chemicals are related to emotions and thoughts. But the salient point is that our state of mind has an immediate and direct effect on our state of body. We can change the body by dealing with how we feel. If we ignore our despair, the body receives a die message. If we deal with our pain and seek help, then the message is living is difficult but desirable, and the immune system works to keep us alive. I therefore use two major tools to change the body: emotions and imagery. These are the two ways we can get our minds and bodies to communicate with each other. Coping with stress. It is often said that stress is one of the most destructive elements in people's daily lives, but that's only a half-truth. The way we react to stress appears to be more important than the stress itself. The onset and course of disease are strongly linked to a person's ability and willingness to cope with stress. Stresses that we choose evoke a response totally different from those we'd like to avoid but cannot. Helplessness is worse than the stress itself. This is probably why the rate of cancer is higher for blacks in America than for whites, and why cancer is associated with grief and depression. The level of stress is determined partly by society. Cultures that place the highest value on a combination of individualism and competition are the most stressful. Those that seem to produce the least stress and have the lowest rates of cancer are close-knit communities in which supportive, loving relationships are the norm, and the elderly retain an active role. Religious faith and a fairly open, accepting attitude towards sexuality are two common characteristics of low cancer societies. Stress can be measured. One of the yardsticks for it, developed by Doctors Thomas Holmes and Richard Raw, uses a list of 43 stressful changes to assess a person's likelihood of becoming ill. The evaluation begins with the history of the person's recent emotional life, then assigns a certain number of points to each life crisis, such as changing or losing a job, children leaving for college, marriage or divorce, moving to a new house, and so on. The highest value, 100 points, is attached to the most grievous loss, the death of one's spouse. This most traumatic of events is often followed by cancer or other catastrophic illness in 1 or 2 years. Recent studies have confirmed that grieving spouses have depressed immune systems for over a year. New evidence suggests that divorce may be even more devastating to many people, since it's harder to accept that the relationship is really over. Indeed, divorced people have higher rates of cancer, heart disease, pneumonia, high blood pressure, and accidental death than married single or widowed persons. Married men also have 1/3 the lung cancer incidence of single men and can smoke 3 times as much with the same cancer incidence as single men. In dealing with the problems presented by cancer, therefore, we must not forget the effects this crisis may have on family and friends, particularly if the patient dies. The doctor must help the others deal with their fears and grief openly in an effort to prevent further disease. When stress is confronted and love is shared, everyone, the family as well as the patient, benefits.